Good afternoon, everyone. This is Debbie Plotnick from Mental Health America, and I'm delighted that you could join us today for the webinar entitled IMD Exclusion, Its History, Effects, and Future Policy Implications. Today's webinar is sponsored by the Mental Health America's Regional Policy Council. Again, I'm Debbie Plotnick. I'm Vice President of Mental Health and Systems Advocacy here at Mental Health America, and I have the great privilege of coordinating our Regional Policy Council. I'll be introducing and moderating today's webinar. Let me invite participants to use the chat box that's on the left side of your screen down at the bottom, so that if you have questions and comments, we'll address them as we go through as possible, and we'll answer questions at the end of the presentations by our speakers. Secondly, I'd just like to remind everyone that today's webinar is being recorded. The audio recording will be available on the Mental Health America website at mentalhealthamerica.net within 2 weeks of today's webinar. You'll also, if you have registered, and I'm assuming that you have if you're joining us, receive an email telling you when it is posted. So anyone who wants to see the slides from today or review the recording, that will all be posted on the Mental Health America website. The purpose of today's webinar is to offer information to participants about the history of the IMD exclusion and to offer a little background, as there's a lot of renewed interest and current talk about the IMD exclusion. We've seen it recently appear in a number of proposed legislative proposals, a number of bills. I have a list of that I'll get to in a minute. It's been the subject of a national demonstration project, which we'll hear about today. It's also been the subject of Medicaid waivers, which we'll hear more about, and the subject of a recent state Medicaid director letter. Again, we will hear about this as we go on. And we're very lucky today to have two national experts with us to offer history and to talk about currently what's going on with respect to the IMD exclusion. First, we have Rusty Felix, and Rusty is a member of Mental Health America's Regional Policy Council, as well as a board member of Mental Health America National, and he's the Executive Director of Policy and Advocacy at Mental Health America of California. Rusty also serves as the Executive Director and Legislative Representative of the California Council of Community Mental Health Agencies. And from that position, Rusty was one of the original authors of Proposition 63 in California, which was a ballot measure which really transformed America's mental health system by finding tax money to help them as they redevelop. Rusty has been a leading expert in mental health policy and finance for the last 25 years, and he's been involved also in state and local government policy and finance for well over 35 years. Rusty has a bachelor's degree in economics from Northwestern University and a JD from the University of California, Davis. Also joining us today is John O'Brien, and John is the Senior Policy Advisor for the Disabled and Elderly Health Programs at the Centers for Medicaid and for Medicare and Medicaid Services at CMS. In this role, John is responsible for advising the center's Medicaid and Children's Health Insurance Program, the CHIP programs, on matters related to mental health, substance use disorders, and also on beneficiaries with complex health conditions. He's currently the program lead for two areas of the CMS Medicaid Innovation Program, substance use disorders and primary care mental health integration projects. He's responsible for the agency's efforts regarding parity. Previously, John was the senior advisor to the Administrator on Healthcare Reform at SAMHSA. John was also the director of several national projects funded by the Robert Wood Johnson Foundation to develop strategies for coordinating human services at the federal, state, and local levels. Prior to joining SAMHSA, John was with the Technical Assistance Collaborative for 15 years as a senior consultant. But he's also provided a great deal of consultation to many states and local human services authorities. So he's really an expert on Medicaid, state mental health and substance use authorities, and he's worked with many states on developing Medicaid waivers, Medicaid state plan amendments, and reviewing federal grant applications. We are really very, very lucky to have John join us today, and I welcome them both. And I'm going to just get started with a very brief reminder of where it is that we've come from. Rusty will go into more detail, but I just wanted to begin with a little bit of a reminder about what the IMD exclusion is. So a rather archaic term to our more modern ears, institutions of mental disease. And you see on your screen a picture of Philadelphia State Hospital, which was very close to where I grew up in Philadelphia. And many, many people remember large state hospitals in their childhood and even presently. Every state has at least one. And these were very imposing edifices that really took over the entirety of their landscape. And the IMDs were places where people spent a great deal of their lives. They really represented in many ways the lives of people who spent decades in these hospitals. There were men, and there were, there we go, advancing the slides, and women, and even very young people and children who spent decades in these institutions of mental disease. Many of them lived their entire lives. Many of them died and were buried on the premises. So as we listen, we'll keep in mind why it was that these institutions came to have an exclusion in Medicaid 50 years ago. And I'm also going to go over a short list of terms that you'll be hearing about as Rusty and John present today, and a short list of legislative proposals that's just for your reference. I'm not going to be going into the details of particular bills, but just wanted to mention that the IMD exclusion has appeared in recent legislation. So I'm going to move to that glossary right now. And so we know that IMD, and you'll be hearing lots of alphabet soup today, institutions of mental disease. We'll be talking about its context in the ACA, the Affordable Care Act, also known as Obamacare. CMS, this is where John is based, at the Center for Medicare and Medicaid Services. We will hear mention in passing of EMTALA, the Emergency Medical Treatment and Labor Act. We'll be hearing from John about the Medicaid Emergency Psychiatric Demonstration, and you'll see it abbreviated MEPD. You'll be hearing about a notice of proposed rulemaking that was recently put forth and a Medicaid director's letter that followed it. Again, this is for reference because we will be talking about 1115 waivers. This is just a short slide to remind our participants of the types of 1115 waivers, and you'll be hearing about their use or possible uses in terms of the IMD exclusion, and as food for thought as we begin our discussion and our thoughts around this topic. Recently, in proposed legislation, this is a list of some of the bills that a short search came up with where we're seeing that the IMD exclusion is coming up, and we expect that it will also be coming up in other proposals. So we wanted to offer this opportunity to take a look at where we've come from and where it is that we may or may not be going, and to help you inform your thinking. So again, I welcome you all and thank Thank you for joining us. And let's begin with Rusty, please. Rusty? Rusty, are you with us? I know we had Rusty on the phone. Rusty, are you unmuted, please? Folks, bear with us for 1 second as we work on a little bit of technical difficulty. Thank you for your patience. We're reaching out to Rusty. We lost him on the line, so we're going to get him back. Again, we're delighted that you've joined us. If you've just joined us, I'll remind you, I'm Debbie Plotnick from Mental Health America, and this is a webinar about the IMD exclusion that is sponsored by our Regional Policy Council. And today we will be reviewing a bit of history. We'll be looking at recent context of where the IMD exclusion has come into play in discussion, in proposal, in state Medicaid director letter, and in national legislation. Okay, Rusty, you with us? You ready to go? I'm afraid I can't hear you, Rusty. Excuse me while I check that one more time. Again, apologies, folks, for keeping you waiting. We had Rusty and we just lost him. Technology is wonderful. There you go, Rusty, you with us?
Can you hear me now?
Yes, we can. You're
Finally,
ready
I don't know
to go.
what was wrong because I could hear you. For some reason, I kept being muted. Okay, so now you hear me. Okay.
We hear you just fine. So
do
you need someone to advance your slides?
Oh, am I able to advance them myself?
Yes,
I
you are.
I do have the screen working. Oh, so I can. Okay, yes, I can advance them myself. Okay,
there you go.
So I was asked to explain how this is looked from a local affiliate's perspective and from a provider perspective in California. So the title of it, I point out the fundamental dilemma, which is the federal government saves enormous amounts of money in Medicaid expending by having this IMD exclusion, and of course that has the opposite effect for the states. And then, of course, it incentivizes the use of services that are not subject to it, and so that creates divisions in the mental health community. So I'll just kind of walk through that a little bit. So first of all, what it is, the term is just a bunch of words. Doesn't necessarily have any inherent meaning, but 16 or more beds is the key term. And it doesn't really matter what else it is as long as it has 16 or more beds and it is for people with mental illness. And if it's not a medical facility and it's not for mental illness, it doesn't apply. Why? As best I can tell, and again, this was a long time ago before I got involved, what I've been told is it was the federal government just simply didn't want to have to pay for taking care of people in state hospitals or other long-term institutional care for people with mental illness. And it dates back to the time when most people were in these state hospitals, and the feeling is that wasn't what Medicaid was for. And so the controversy has come as applied to acute hospitalizations. Now, most acute hospitalizations take place in general hospitals, not psych hospitals. But if it's in a psych hospital, then it's viewed as taking place in an IMD. And there's a pilot program that John's going to go into much more detail about that exempts a few facilities in about 12 states. And I don't have a lot of details on it, but John does, so I'll let him speak to that. The fact is that for the whole 30 years that I've been doing mental health advocacy, as best I can tell, every state Medicaid agency and every psych hospital has been trying to find ways to end the IMD exclusion, arguing that it simply reduces federal share of cost for something that's an inherent part of mental health services for people in Medicaid. Since we've had the Olmstead court decision for roughly 20 years, that requires people be treated in the least restrictive placement. So as long as you're in compliance with Olmstead and somebody still needs to be in a restrictive setting, why do we need the financial incentive on top of that is the argument they use. And then, of course, the psych hospitals say it discriminates against them as compared to general hospitals and puts pressure on states and communities to go to a general hospital licensing, which is often more expensive than the type of facility that might meet the needs, which would be less expensive if we didn't have this rule. So the mental health community has been divided for as long as I know. Generally speaking, we've had families and the medical community want to end it. Consumer and disability advocates like it because it incentivizes more investment in community care. Providers are divided. They like the financial incentive, but they recognize that states are losing the federal funds. And then we've had this big push for an exemption for unlocked residential facilities because of the 15-bed rule. The general belief is those were never intended to be viewed as IMDs. They're really a different level of care. And, of course, we've seen the progress recently, particularly as to substance use disorders. And, again, John can go into more detail, and I'll cover a little bit more about that. So the reality is that there's a bill in Congress that was introduced last year actually trying to directly amend this, and I was told that the 10-year scoring on it was $400 billion. So this year they wrote it to say only to the extent to which CMS finds it cost neutral, and the general belief is it's not going to find it cost neutral at all, although that pilot study might show that it is. So the focus has been on narrow changes, the acute hospitalizations pilot, and then this unlocked residential facilities with limited medical care. Arguably it's not an IMD. You're kind of fudging on the range of the definitions, but this has been doable through CMS waivers without statutory change. And California put the first one of these through in what it's called its substance use disorders organized delivery system, moving from a fee-for-service system at the state level to a county-level organized delivery system, which will be managed care contracts. And these facilities seem to be an integral part of that, and that the providers have said that if restricted to 15 beds or less, you could not make any of the current ones pencil out, and you'd make the program much more expensive. And on that basis, the CMS waiver was approved, and guidance to other states went forward. Again, John will provide more detail on that. So the premise that differentiates substance use from mental health is that this residential care component in recovery is viewed as virtually always one of the steps towards recovery, much less so for mental illness, and that may be why this has moved ahead, that the IMD exclusion has not prohibited the need for the residential care for severe mental illness to any significant degree. Certainly the providers would like to get rid of the exclusion, the 15-bed limit is what they see it as, but they've been able to make the facilities work at under 15 beds. In substance use, we're hearing that's not the case. The important thing is there's no controversy to this. So all the normal controversy as to the IMD waiver has not applied to this. There's been no element in California, no constituent group that thought this was a bad idea. Everybody thought this was a good idea. There was legislation urging the state to seek it, and there were, as far as I could tell, no votes and no one testifying against this at all. Not necessarily the same in mental health, where there's alternatives to residential care, and there are a number of interest groups that don't support even unlocked residential care, but we think that short-term crisis facilities may well be an exception that may warrant some expansion of eliminating the 15-bed limit, although again, some are operating with the 15-bed limit in mental health, and it's not doesn't seem to be the prohibitive barrier that's been in substance use disorder treatment. That's it. That's my presentation, and happy to answer any questions if you feel we should take them at this time or should wait until John's done.
Well, let's move on to John, because John is going to talk about many of the things that you mentioned, Rusty, and then folks will have a bigger picture. And so without any further ado, John, are you with us and ready to go? Oh, we're having problems here today with John, getting him unmuted. There you go. John, you with us? John, are you ready to present your slides?
He's probably having the same problem I had.
Perhaps, John.
There's some, your unmuting switch isn't working.
John, you want to try *7?
Hi, it's John.
Hi, John. You're good to go.
There we go. Well, welcome everyone, and thank you for inviting us to this very important topic. We actually have a number of things to be able to talk about that we've done in this space over the last 18 or 24 months. Let me clarify, though, that the IMD exclusion, the language was actually drafted and enacted by Congress, and for better or for worse, the Centers for Medicare and Medicaid Services is the enforcer of that congressional statute, and that's why I assume that many of you are on the phone, and many of you have been probably working as part of MHA or its affiliates to have conversations with Congress about the statute. However, they have also, they being Congress, has given us an opening as part of the Affordable Care Act, and we at CMS are also trying to work on some of the options that we think states might have, legal options states might have, to be able to address some of what I hear they're concerned about as it relates for institutions for mental diseases, whether we're talking about mental health, whether we're talking about substance abuse, whether we're talking about older adults between the ages of 22 and 64, which is primarily where we've got the largest issue, but also children as well. The IMD exclusion does apply to children, but there are options that states can use that are a little bit more straightforward than some of what I'm going to talk about today. So if we go to the next slide, I'm going to talk a little bit about Section 2707 of the Affordable Care Act, which Debbie and Rusty had referenced, which is the Medicaid Emergency Psychiatric Demonstration, which technically ended this year or at the end of this calendar year, but for all practical purposes, where we're at with the project, states were completed several months ago in May. I want to talk a little bit about the State Medicaid Director letter that we put out on substance use disorders back in July of this year, and then highlight some of the language that we had in our managed care notice of proposed rulemaking. And while I know this will be frustrating, I can't say much about that in terms of Q&A because we are still in the process of moving that notice of proposed rulemaking to a final rule. So if we go to the next slide, let's talk a little bit about Section 2707 of the Affordable Care Act. And let me just do an overview of the Medicaid Emergency Psychiatric Demonstration Program. So back in 2010, when the Affordable Care Act was passed, it authorized the Secretary to conduct an evaluation and evaluate that, conduct the demonstration and evaluate that demonstration that would look at the payment of Medicaid to private psychiatric hospitals that were institutions for mental disease. And the legislation was very specific that it was private psychiatric hospitals, so it did not include state hospitals. Again, it was focused on adults ages 21 to 64 that had emergency medical conditions that were psychiatric in nature. And it provided federal financial participation, which is the way that we pay states their federal match for the providers that were participating in the psychiatric demonstration project. If we go to the next slide, it should list the states that were participating in the Medicaid emergency psychiatric demonstration. Again, I was on the review committee. We, I think, had about 20 states that had raised their hands, maybe a little less, who were interested in participating in the emergency psychiatric demonstration project. There was a capped amount that was available through the Affordable Care Act, I believe, of $75 million. And some of that, of course, was for the evaluation, which has been ongoing since this program started several years ago. If we go to the next slide, I can begin to talk a little bit about some of the preliminary results. And the reason I'm saying they're preliminary results is because they are a point in time of about a year and a half ago, and we will, of course, have a final evaluation probably within the next 12 to 18 months that will be the final results of this project. So, as of the point in time that we did the evaluation, we had 11,552 admissions. Here's the reasons why that people were being admitted to the Medicaid emergency psychiatric demonstration. Many of them were admitted with a diagnosis of mood disorder, and again, about a third with schizophrenia or psychosis. The rest were other types of disorders, including anxiety disorders, substance use disorders, and kind of a catch-all mental health diagnosis. But predominantly, it was mood disorders, schizophrenia, and psychosis. And not surprisingly, many of them had a primary or secondary discharge diagnosis of substance use related disorders, and we probably feel like that may be on the low side. But again, highlighting that this is not just clearly a mental health issue or a substance use issue. It is often a comorbid issue. Next slide. So the average length of stay, while there was a very wide range of less than a day to a little over or almost 5 months, the average length of stay was about 8.5 days. And that is fairly similar to what we see also on the length of stay for visits to acute care hospitals that Rusty was referencing that had psychiatric distinct part units. So that they are general hospitals that have a psych wing to them. 92% of the individuals were discharged to home or to self-care. Only 8% were transferred to another facility, or they left against medical advice. They were in hospice. Perhaps they died, or the information was not available. During the time, and again, this is generally about the first year, year and a half of the project, 21% of the individuals that had an initial admission into an IMD were readmitted to a participating IMD during that period. And then the total expenditures were just under $78 million. So I guess it was a little over the $75 million that I had first mentioned. And there's the average cost per admission, which again is federal state of a little over $6,700. Next slide, please. So in addition to some of the quantitative information that we're collecting through the evaluation, I thought it would be helpful to highlight some of the qualitative information as well. Part of, I think, what was the genesis, and Rusty, you probably know better than I of some of the genesis around the emergency psychiatric demonstration, was that there was a tremendous amount of boarding that was happening in emergency departments in general hospitals, and it was very difficult in some respects to transfer those individuals from a emergency department in a general hospital to a bed in institution for mental disease, because there was going to be no payment for that individual if they tended to be between the ages of 22 and 64. And so, some of what we did find that it was that this demonstration did allow for an easier transfer, from emergency departments to IMDs, and diversions from the emergency departments themselves. There were still waiting times that were for a bed that contributed to increased boarding time, but unfortunately some of those are administrative in nature. Some of it was the hours of operation for admissions to the IMD. Some of it was just how hospitals do discharges and how clunky sometimes those discharges are. Some states continue to report particularly high levels of boarding in in emergency departments on weekends, and some of the emergency department staff, when interviewed in a few states, reported that some of the IMDs did not accept individuals with comorbid conditions. So some interesting qualitative information. If we go to the next slide, there were some additional results that I thought were helpful to highlight. One of the, I think, important preliminary results is that the linkages between the IMDs and the providers in particular communities really strengthened as part of this demonstration, where before they may not have had much of a relationship, again because of perhaps because of the IMD provision. Those discharges were strengthened, and hopefully those transitions worked much better than they would have in absence of this demonstration. But part of what we heard from the IMDs and the staff in those facilities is that there's still, and not surprisingly, a lack of available outpatient services, especially psychiatrists, which made discharge planning difficult in their mind. And then, for better or for worse, there still seems to be an issue with being able to find good housing for individuals that are being discharged from IMDs, and unfortunately there were a number of states that were reported that they were discharging patients to homeless shelters. So I think that at least for the point in time for the evaluation, that gives you a sense of some of the quantitative and qualitative preliminary findings for that project. Let's go to the next slide. So as you may or may not know, we have been spending a fair amount of time over the last 4 years looking at substance use disorders. Some of that, of course, was being prompted by a number of states that were expanding, and as a result of expanding, they were going to have to cover substance use disorder services, and we're beginning to ask what would be the substance use disorder services that would make sense, in the year 2012, 2014, because some of them had not touched their state plans for many, many years in this area. In addition, as we began to work with states that were doing expansion, and as we put out another state Medicaid director letter on mental health parity, a number of states were beginning to look at their substance use disorder benefit, and also not only look at the benefit, but whether or not there were certain limitations on that benefit that may, in fact, prevent access to SUD. But we also looked at some of the numbers because we feel like it's really important to make sure that some of our decisions are data-driven. Not surprisingly, we found that 12% of the adult Medicaid beneficiaries had a substance use disorder, and working closely with our partners at SAMHSA, there was a projection of 15% of the individuals in the expansion population would have a substance use disorder. While the data is a little bit old, I think some of the information in this slide is telling that Medicaid is accounting for 21% of all the substance use disorder treatment costs, and we anticipate that if you look at that number in a few years, that's going to be significantly higher, again, because of some of the expansion efforts as well as we think some of what we might see, but not so much as it relates to treatment limitations maybe being lifted on substance use disorder services. Not surprisingly, as we find on the population with mental health issues, there's lots of comorbid medical conditions, and we are spending in excess of $3 billion on a little over 500,000 people that we had as part of a study we did on substance use disorder. And then last but not least, we can't ignore the fatal overdoses and the opiate epidemic that we're seeing in 2015. And again, it's quadrupled in the decade before this one, and we know that even in the last few years, it's been increasing, unfortunately. So that was really, some of our business case of why we wanted to focus on substance use disorder. If we go to the next slide, I think you get a better sense of even looking at rehospitalizations. And obviously, mental health and substance use disorder are pretty predominant on the Medicaid side versus the Medicare side. And when you look at alcohol-related disorder and substance-related disorder, those were pretty significant in Medicaid. And I think for Medicaid directors, that was eye-opening in some respects. So let's go to the next slide if we can. So some of the work that we did in terms of data analytics, some of the work that we did in terms of parity and our alternative benefit plan led us to develop a state Medicaid director letter. And the state Medicaid director letter was just not about giving states some relief around institution for mental diseases for individuals with substance use disorders. It really was looking at how can states transform their system for individuals with a substance use disorder, not only treatment services, but also recovery services and physical health services. And while certainly there's transformation to be done on the mental health side, there were other vehicles and other opportunities that we saw and have put into place to address some of the state's interest in doing mental health reform. But this state Medicaid director letter was focused on SUD, and it encouraged states to use what we call a 1115 demonstration waiver for this transformation. And part of what we're hoping to do as part of the state Medicaid director's letter is that each one of these 1115s are going to have an evaluation. And hopefully we're going to have a consistent evaluation across the states that are raising their hands, saying they're interested in this. So we will have good information. We will have good data around the effectiveness of substance use disorders, which is really important for the field. And then last but not least, there are 13 expectations that we set for states that if states are going to pursue an 1115, they must meet in order to be granted that waiver. So let me go to the next slide. And let me talk a little bit about the expectations that are in the state Medicaid director letter. And so one of the things that we had felt pretty strongly about is that states could do better with their benefit design, both for adults as well as for adolescents. When we did a snapshot of what states were buying in terms of substance use disorder, we found that it was pretty treatment heavy, again, which is fine, but not a lot in terms of either early intervention or recovery services, and that there were components of the benefit design for treatment that were missing, including residential treatment. And for a number of reasons that Rusty talked about, providers that were offering substance use residential treatment were larger than 16 beds. And they were predominantly serving individuals with substance use disorder. So they met the characteristics of the IMD, could not get Medicaid reimbursement, and therefore we felt like it was going to be important to figure out how states through the use of cost savings, could in fact be able to look at and finance some of the services for individuals that are in an IMD. One of the things that's important to recognize is that the IMD is a payment exclusion, so it's not a service exclusion. I know that might be nuanced, but it is a payment exclusion, so that if this person is in an IMD, then that person, while still Medicaid enrolled, the providers of the services, once that individual is an IMD, are not eligible to receive Medicaid payment until that person leaves the IMD. So we also realized that that was going to be another issue, especially if we were interested in having individuals have health care services or access to health care services while they were in a residential facility. We felt as part of our expectations that we had to be clear about what we expected from states and their providers around the treatment that was going to be available to individuals with SUD, and therefore we used the industry standard, which was the American Society of Addiction Medicine criteria that details what the level of care is for various treatment services, as well as the placement criteria that somebody would have to meet in order to be in that level of care. We also felt that it was going to be important for states to have a network development plan. While states might be ready to have each one of the services in the treatment continuum, we also know that they're not available in all parts of the state or as much as what the demand is, and so we asked that states have a network development plan, a good care coordination design, because transitions between levels of care is critically important, and especially on the substance use disorder side, the propensity for people to leave treatment because of not having good handoffs is pretty high. Integration with physical health care is tremendously important because of the level of comorbid condition. We wanted states to be having some conversations with their constituents and have a plan to address prescription drug abuse, as well as an opiate strategy that's consistent with the Secretary's strategy, HHS Secretary's strategy that was put out about a year ago. Next slide, please. And then here's the remaining program expectations. Program integrity and provider business operations are really important in terms of a transformed system. We had a number of states where there were issues with providers billing, perhaps some fraudulent billing, and we wanted to make sure that we weren't putting providers and therefore clients at jeopardy if in fact there was going to be some program integrity issues, and be proactive about having work or doing work with providers in this area. Benefit management in terms of how we made sure that people were getting the right service at the right time. Again, the focus on services for adolescents and youth, which we messaged last year with SAMHSA around the need for adolescent treatment to be consistent not only with ASAM, but also to think a little bit more about recovery services and cutting-edge recovery services. We lay out what the quality measures and the metrics and the data analytics are that we expect from states. Again, every 1115 is supposed to have an evaluation, so that's not really an additional requirement per se of the 1115. We're just being a little bit clearer about what we're asking states to collect. Because this is substance use disorder, we wanted to have states, especially the Medicaid agencies, partner with their single state agency for substance use disorder. And then last but not least, pay attention to community integration. We released some home and community-based services regulations almost 2 years ago, and we felt that there was some really good direction in terms of what we hoped services for people with disabilities and substance use disorders could benefit from as part of an integrated set of services. So I think that's it for the state Medicaid director. Let's go to the next slide. Oh, well, I spoke too soon. But anyway, we are being clear that, we are building off the American Society of Addiction Medicine's continuum of care. We are saying to states that short-term residential care, on average 30 days, and that's important, that on average 30 days. We recognize it could be less, it could be more for a particular level of care. Is consistent with the ACAM criteria. We're really encouraging states to be creative about their aftercare recovery and support services, and also think about what are the housing supports that individuals with substance use disorder are going to need. Since, again, it's an area where we find that there is a fair amount of discrimination. Next slide. The last part of the discussion is the managed care notice of proposal rulemaking, and again, we are in the process of reviewing the comments, responding to the comments, and finalizing the regulations. So I'm not in a position to talk much about the reg itself. But, again, just a little background that Rusty gave and that I just talked about, that federal financial participation is not available for medical assistance for services provided to an individual age 21 through 64 who is a patient of an IMD facility. And what we do is clarify that managed care plans have some flexibility under risk contracts to provide alternative services, or what is often known in a technical term, in lieu of cover services, if they can show that that service is cost effective, that it's offered on an optional basis, and that both the plan and the enrollee agree that the service would provide the medically appropriate care. So bottom line is that you can't make a beneficiary accept in lieu of service that they don't want to accept. And, what we had seen in a number of states is that the managed care plans of the state had often defined IMDs or psychiatric facilities, and in some cases residential facilities on the substance use side, as an in lieu of service. I think what we were hoping to do and are hoping to do as part of this managed care NPRM is to allow those plans to continue with that practice because they're addressing a need for beneficiaries for service that may not be available in that beneficiary's community. Next slide, please. And so we did set forth some language that clarified the types of facilities and the length of stay as it relates to individuals and IMDs that managed care plans could buy for in lieu of services. And so we said an inpatient hospital facility. We did not specify private or public, or a subacute facility providing crisis residential services. We had certainly known that there were a number of states that had crisis stabilization units, some of whom were under the 16-bed limit, some that were over the 16-bed limit, but we felt like it was important to put this in the NPRM to see what people thought about that particular provision. And again, we messaged that the length of stay in the IMD is for a short-term stay of no more than 15 days during the period of the monthly capitation payment. And again, that is based on some of the information that we had, not only from the Medicaid Emergency Psychiatric Demonstration Program, but other claims information. Next slide. And here's some further information, the State Medicaid Director's Letter. If you want to email me about the substance use disorder SMD letter, you can email myself or Elliot Fishman, and then the link to the managed care notice of proposal rulemaking. So I believe that's it, Debbie.
John, thank you so much. Rusty, thank you so much. That was an incredible amount of information in a very short amount of time. We do have some questions, and I invite folks to please offer more questions in the chat box, and we'll do our best to answer them in the time that we have today. Let me start with some questions that came in early. John, can you just very briefly, we know that the IMD exclusion affects folks between the ages of 21 and 64. Can you just give us the very short version of what's the kids' deal with this?
So the kids under 21 and older adults over 65, the state has to explicitly request in their state plan inpatient psychiatric services and an IMD for those age ranges. So it's a state plan service that states can access, but again, it's an optional state plan service.
Great. Thank you, John, for clarifying that. We had a couple of questions come in around that. Another area that we've got a number of questions around are the comorbid conditions. You mentioned that a number of facilities in the demonstration project didn't want to take people with comorbidities. And people were wondering if what those comorbidities were, and specifically if a lot of the comorbidities were substance use conditions that the facilities felt they were unable to treat.
Debbie, that's right. I think almost all of the facilities that said they didn't treat comorbid conditions, it was around mental health and a comorbid condition of substance use disorder. If there was a comorbid physical health condition that really had to be treated before the mental health issue, obviously those IMDs wouldn't be in a position to be able to serve those individuals, but hopefully, an inpatient hospital, general hospital could and either treat them on their distinct part unit for psychiatric services or refer them to an IMD.
Okay, thank you so much. Another question that was asked was if you have a ballpark you can give us for the percentage of Medicaid spending that is now used to treat substance use disorders.
I don't have that.
Okay, that's a big question. So one of our participants asked, and that of course will be difficult to project as we move forward and more people are stepping up for substance use treatment. You also mentioned that one of the biggest problems with the IMDs who participated in the demonstration project, they noted it was the lack of outpatient services and housing. And this seems to be an issue, Rusty, feel free to jump in here too, please. This seems to be the kind of underlying issues for what the IMD exclusion historically was put in place to do, so that we know that there was a desire not just to manage costs between not having the federal government pay for what was considered to be the state's responsibility, i.e. the state hospitals, but also to encourage the development of outpatient and community services. And so I guess it's not surprising, although certainly disheartening, that that was one of the largest problems that was reported, was the lack of outpatient services to hook folks up to once they were finished their stay in the demonstration project facility, and that of course also related to housing issues. Would either one of you like to comment on that?
Well, sure, I can comment on that. I mean, I think that, I can't speak to what the original congressional intent was in terms of the IMD exclusion, in terms of incentivizing outpatient. But obviously, every healthcare manager knows that if you have more outpatient, you need less inpatient. But what I find is the phenomenon of what I call the tipping point, and you can get a tipping point in both directions. That when you're in a state when resources are rising, and of course we're just coming out of a period when resources were falling in a recession in state governments, when resources are falling, the outpatient gets cut because it can be cut. It's a discretionary service. Almost all inpatient in California is involuntary, and the feeling is the state has to pay for that, or the counties have to pay for it in California. And so you reach a reverse tipping point. You cut the outpatient, that increases the demand for the inpatient, and it just backs up. And then, of course, in good times, then you hope to get to the tipping point that goes the other way. As you expand outpatient, then the need for inpatient goes down, and then you have frees up more money to expand outpatient. So it's more a function of the economy, I find, than policy. that deals with this. Although I would add one other thing, which we've seen recently, is our State Hospital Association did a study 2 years ago and said that only 1/3 of the people taken to the emergency room, but this relates to the emergency room boarding, ever meet the criteria for a psychiatric hospitalization. 1/3 of them really can go home. 1/3 need crisis residential, and that's in much shorter supply than even hospitals. So that a lot of the, capacity in the hospitals that people say is needed really isn't needed if you would invest fully in the non-hospital crisis care system, which has become a major priority in California in the last 2 years to dramatically expand that. The goal is to have 2,000 new beds. It's too early to tell how much that will impact the hospital need. But the other issue about the lack of follow-up care is a real problem. It clearly is a violation of law to have somebody hospitalized and not have the follow-up care. And it's also an issue that to me is even worse in the private sector than it is in the public sector in terms of the fact that most commercial plans don't even have relationships with the types of providers that can provide the intensive level of outpatient care that anybody who's sick enough to be hospitalized is likely to need for a period of weeks of months when they come out. And we see that as a major parity fight that we are disappointed that the federal regs weren't more specific on this. But the courts so far seem to be pretty consistent that if it's a medically necessary level of care, it needs to be there. That we think is a huge factor, because if we can get the health plans to recognize that they have to provide that care, that should expand the supply, and then there will be significantly greater capacity. It's kind of a off the direct question answer, but it raises a whole lot of policy issues.
Thank you, Rusty. There are indeed many of them. Let me ask a process question if I can. We have a question from a participant in the webinar about how many states would be impacted by the Medicaid managed care proposed rule. John, can you address, let me put it another way. The question from the person was how many states, but can you address how states will be impacted by the Medicaid managed care proposed rule?
So I don't know if we have an exact number of the number of states that will be impacted, meaning those states that will choose to, if the reg were to be finalized, choose to move forward with in lieu of services. We've got, I think, 37 states that operate some sort of managed care, but that doesn't always mean that behavioral health, mental health, substance use services is in that managed care. So, again, there's not lots I can say here about what the impact is, because that's part of what we asked for as part of the NPRM. But in states that have been doing this, let's put it in that context, it's a matter of the states working with their plans to identify what in lieu of services are, describe those in lieu of services, and then again figure out how to price those in lieu of service, just like they would if it was a non-mental health in lieu of service. So what that looks like moving forward, it may look a little bit different. It may not, again, depending on what the final regulations state.
And folks may be confused a little bit about what in lieu of service means. And so it's a concept that we're seeing more and more, especially as managed care comes into things, that we know that there are certain benefits on medical side, on behavioral health, substance use side, that are considered to be medically necessary or that fall under existing law. And so it allows for flexibility of substituting one type of service for another, specified as in lieu of. So, John, if I understood you correctly earlier in your presentation, you mentioned that some managed care organizations in managing services are already using larger substance use facilities than 16 beds, more than 17 beds, as an in lieu of service because there are no other services that are available to folks. Did I understand that correctly?
That would, we know of some states that are doing that, yes.
Okay. Are states also doing that with respect to non-substance use services, other types of psychiatric services? Have you had any notice of that or requests for that?
They have, and we've had to deny those requests.
Okay. So we've been, that was some of our listeners have asked about being a little confused as to what applies to substance use and what doesn't. My understanding, please help me if I don't have this correct, and this may be helpful to webinar participants, is that when the IMD exclusion was enacted as part of the Medicaid authorizing legislation 50 years ago in 1965, that substance use facilities did not exist as they exist today, and substance use did not come under that until much later in the medical coding. I think it was the ICD-9, and I'm not sure on the dates. Maybe one of you can help me clarify this, but perhaps it was the 60s or the 70s where substance use disorders were then considered to be mental diseases, and that was how substance use facilities then came to fall under the IMD. So that what we're hearing about is how to address problems that came after the original intent. Would either of you like to comment on that, please, or help clarify?
Well, I will just say that you're right, Debbie, that it came after the original enactment of the Medicaid program. It was in the 70s. We did put out program guidance around IMDs as it related to chemical dependency. That's what folks were calling it at that time. And again, part of what we're trying to address through the 1115 is to think about what flexibilities we can offer states to be able to reach some of those residential facilities for individuals with substance use disorders that do meet the ASAM level of care.
Right. Very good. Thank you, John. So it seems that we're in addressing the problems, we're still dealing with the fact that we have different criteria, we have different, if you will, rules that sometimes get caught up and sometimes get separated between what we think of as the, if you will, mental illness conditions versus the substance use conditions. And so folks are sending in questions asking about what it means in terms of the reduction in the number of traditional uses of psychiatric beds that we've seen over the last decade. So we've had closings of state hospitals, we've had closings of general hospital psychiatric units, a great deal of attrition in those types of facilities. So is there anything in recent times that will address that other than the emergency psychiatric? And if so, how do these things play out as we move forward in anything you want to speculate about? I understand we don't have any concrete proposals on the table. Comments? Okay, so we've got a lot more. We've got the same questions we've had for a long time, and that's really the reason that we wanted to offer today's discussion, so that we could really begin to think about what's the lay of the land as it is now. How did we get there? How did issues like substance use come to be involved in an IMD? How are we doing with looking at using, if you will, what currently exists as an IMD, and what we've seen is that we still bump into the same lack of community services. So we still are facing the same types of very difficult questions that we need to think about as we move forward. I'm not seeing any other questions from our listeners at this point. would either Rusty or John like to offer any other thoughts that will help people as we just think about moving forward? And again, Mental Health America, nor certainly not CMS, are offering any particular ways to go, merely information to think about it as we move forward. Well,
Debbie, it's John. I mean, I think that, it's going to be, I think, very important for you and your members, as Rusty, I think, said earlier, to understand kind of what is the IMD exclusion and understand, some of the barriers to the IMD exclusion. And I think that, there are some stakeholders in states that have different views about what should be done here. So, the clearer that you all can be, the probably clearer some of the federal policymakers can be on this.
I would add one other thing I would say is, in my experience, I found that every single type and level of care is the right place for one person and the wrong place for another person. And you need a full continuum, and you need incentives and the ability to get people into the right place. And we have a long ways to go. And I think the new guidance from CMS helps a lot. And I also think that the biggest thing that's going to bring about change in the coming few years is going to be the CCBHC demonstration program, which I think will expand and will eventually become a waiver model that will start to build that non-hospital system up to where we don't have these problems nearly as often as we do now.
Rusty, you offered a little bit more alphabet soup. I know what it means, but you want to just tell our listeners what you're referring to?
Oh, okay. So there's a law passed by Congress in 2014, known as the Excellence in Mental Health Act, that was Section 223 of PAMA, Protecting Access to Medicare Act. It would seem not to fit there because it has nothing to do with Medicare. And it allows a demonstration program for 8 states for 2 years to have a significantly higher federal share of cost for community mental health center, or community behavioral health center, because it's mental health and substance use disorder services, outpatient services, not residential or hospital, recognizing that the federal government's invested heavily in building up the capacity of federally qualified health centers so that there's primary care for low-income people, the safety net is there, and there's a recognition that there's been an underinvestment in behavioral health. And this is intended to ramp up that funding, and there's a lot of complicated rules, and under the current congressional authorization, it's 8 states for 2 years. We're aware that state Medicaid directors believe that CMS could grant waivers that could expand this, not likely the higher federal share of cost, but there's some payment model forms that helps expand this as well, and there are measures pending in Congress to expand this. The National Council, the sponsor of it, believes that this will expand and eventually they think be 50 states and permanent because of all the things that came up that John mentioned about the lack of follow-up care in hospitals, and that's a huge problem in behavioral health, and that's a much bigger problem than whether we do or don't have access to the facilities for crisis care. And the more we spend on crisis care, the less we have for the non-crisis care.
Thank you, Rusty. And John, thank you very much. I really appreciate both of your expertise. It's helped frame a really complicated issue that's been with us for a long time, and the efforts to look at it in its present context. And Rusty just gave us a little bit of a taste of one of the potential ways that we could do it in the future, and we can do future webinars examining the community behavioral health clinic project. But we're not up to that one on this one, but thank you for bringing it to our attention. And thank you so much, both of you, for sharing your expertise and for taking the time today. And again, we will put all of the slides and the audio recording of today's webinar on the Mental Health America website at mentalhealthamerica.net. And we really, again, appreciate you joining us. So thank you, and we'll say goodbye now.